a case of incomplete scimitar syndrome in a quinquagenarian male. We present a case of a 59-year-old male with chief complaint of dizziness for 3 days. He had a history of hypertension, diabetes, prior myocardial infarction, and cerebrovascular accident. He denied vertigo, tinnitus, fever, chills, and chest pain. Vital signs: blood pressure 234 by 122 millimeters of mercury. Regular rhythm, heart rate 61 beats per minute, 99 Fahrenheit, saturating 98% on room air. Physical exam: systolic pulmonary outflow murmur associated with a widely split and fixed second heart sound in the left parasternal area. No jugular venous distension. He was initially given 10 milligrams of hydralazine, which decreased the blood pressure to 191 by 90, followed by labetalol 10 milligrams, which decreased it further to 164 by 92 millimeters of mercury. A few hours after he was initially evaluated, he developed altered mental status. Blood pressure at this time was 195 by 95 millimeters of mercury and heart rate 86. The patient was admitted to the ICU. Imaging results: EKG showed a sinus rhythm of 90 beats per minute with no significant ST segment T-wave changes. Chest X-ray evidenced prominent vascularity bilaterally, including a right-sided scimitar vein. Chest CT, patchy ground glass mosaic pattern opacifications with right-sided predominance with an aberrant connection of the right lower pulmonary vein to the inferior vena cava. A transthoracic echocardiography revealed a normal left ventricle with preserved contractility, with left ventricle ejection fraction of 60 to 65%, a moderate concentric left ventricle hypertrophy, and mild diastolic dysfunction. Right ventricle of normal size and systolic function. Left and right atria were borderline dilated. Noted for mild mitral regurgitation and trace tricuspid regurgitation. In the subcostal view, a large anomalous pulmonary vein drains into the inferior vena cava with no pulmonary hypertension. Mean pulmonary pressure was lower than 25. The patient did not have other associated congenital heart defects. He was diagnosed with incomplete scimitar syndrome. Management: nifedipine 30 milligrams and labetalol 200 milligrams every 8 hours to treat his hypertension. He was started on ceftriaxone for the urinary tract infection he presented. Outcome: the patient showed clinical improvement with resolution of symptoms. The literature on this condition is limited. There are 21 reported cases of scimitar syndrome and 4 published cases of incomplete scimitar syndrome by searching PubMed database from 2014 to December 2024. Currently, the recommendations from American and European guidelines are to consider surgery for congenital heart disease in adults with partial anomalous pulmonary venous return if a left to right shunt is over 1.5 or if there is functional impairment present. Conservative management remains a reasonable approach, reducing unnecessary invasive procedures. Our case highlights a rare congenital malformation that can present with non-specific symptoms either in the newborn period or later in adulthood. Imaging studies are essential for diagnosis, and surgical intervention may not be necessary given the low left to right shunting. The incomplete scimitar syndrome remains poorly understood due to the absence of large-scale studies. Therefore, further research is necessary to comprehend the condition and optimize management strategies and long-term outcomes of adults with this condition. O que tem que fazer agora?
Cadê aqui?